Hey, welcome to our webinar today, everyone. My name is Ron Myers. I'm the Director of Editorial here at JoVE. And I'm pleased to bring you our webinar today, which is focused on a novel approach to glaucoma study. So today, Rafael Lani Lozada will be speaking. His group published with us in 2022 on this glaucoma study. So today he's going to be updating us on the technique, any recent developments. Um, I should let you know that we are recording the webinar, so we'll send all the registrants a recording afterwards. And we'll also be doing a Q&A at the end, so feel free during the presentation, just feel free to add your comments in the Q&A and we'll address those towards the end. Okay, so I will let Raphael begin. Thank you.
Thank you very much, Ron. Thank you, Smita, for the invitation. It's a great pleasure for me to be here. So I'll be talking about this novel approach to glaucoma study. I am Rafael Lousada. I'm an ophthalmologist from Brazil, and I am glaucoma specialist and neuro-ophthalmology specialist. So I hope you all enjoy this webinar. So let's begin. So first of all, talking a little bit about this disease called glaucoma, that it's a sight-threatening disease that is expected to affect more than 100,000 million people worldwide in the next few years. So glaucoma is a neurodegenerative disease that affects specifically the retinal ganglion cells. That is, these cells here, they compose the third neuron of the visual pathway, and their projections, their axonal projections, form the optic nerve here in the posterior part of the glove to see the world around us. So here it's a picture of a normal optic nerve disc. That is the first part of the optic nerve. So this is a healthy patient. And what happens in glaucoma is that the axons of the ganglion cells start to degenerate. The soma of these cells also degenerate. And progressively, this optic nerve starts starts a process of atrophy. But one of the hallmarks of the disease is this optic nerve excavation or optic nerve cupping. So if you see here in this picture, this central part here of the healthy optic nerve, it starts to increase. So the nerve starts to become more excavated. And all this part is related to the death of these axons of these cells. And clinically, so here we see again the healthy eye with a healthy visual field, and progressively as the disease gets worse, this optic nerve cupping gets worse also, and the visual field of the patients start to become more concentric, and the patients can end up becoming blind. And this is an irreversible blindness. And when we talk about glaucoma, we must talk about the intraocular pressure. So we see that these patients, they become more sensitive to the intraocular pressure. And actually, this is the only modifiable risk factor. So many people get a little bit confused of the definition of the disease. So high intraocular pressure, it's not actually the cause of the disease, but it's a risk factor, the most important risk factor and the only modifiable one. We have some glaucomas that they happen with a normal intraocular pressure patient. So what we see is that these patients, they tend to get more sensitive to high intraocular pressure or high IOP. But as a risk factor, it's not the only in a higher risk to develop glaucoma. Race also, and this is really variable. Family history, genetics, and thin central cornea, high myopia. So there are many risk factors to develop glaucoma. So as I was saying, this is the lateral geniculate nucleus of a non-human primate with glaucoma compared to the control. So we see the atrophy not only in the retina, but also in some central targets in the brain. Here is in the occipital cortex of these animals submitted to a glaucoma model. So here we see the control, and in the macaque, we see some atrophies in this band format here. And as the only modifiable risk factor for the disease, the only thing that we can offer patients right now is to lower the intraocular pressure. And we can do that through eye drops, hypotensive eye drops, through incisional surgeries, for example, the trabeculectomy, the tube shunt implantation. We can also offer patients with some laser therapies, such as trabeculoplasty, and some microinvasive surgeries, as the goniotomy procedures. Here it's a Cahut dual blade surgery. But what we see in practice is that 15 to 46% of patients still progress to blindness over 10 to 20 years with the disease, even though we reach the target intraocular pressure for them. Why that? Because this is a multifactorial disease, and it's much more complex than we expect, and we still are learning a lot about the causes of glaucoma. So as a multifactorial disease, we see many things related to glaucoma, for example, mitochondrial dysfunction, endoplasmic reticulum stress, ischemia, high intraocular pressure, neurotrophin deprivation, glutamate excitotoxicity, and all these different forms of injury, they end up with the programmed cell death of the retinal ganglion cells. And there are many types of death for these cells in glaucoma and in other neurodegenerative disease, for example, apoptosis and necroptosis, pyroptosis, ferroptosis. So all these, they're related to glaucoma. And actually for patients, what we try is always to decrease intraocular pressure. As I said, it's the only modifiable risk factor for the disease. But for us to study more about the etiology of glaucoma in the animals, we always try to increase the intraocular pressure for us to try to mimic glaucoma in the experimental setting and to be able to study more about this disease and to find more effective therapies. And there are many types of experimental glaucoma in rodents and in bigger animals. For example, we have the laser photocoagulation of the limbic area here. We have microbead injection in the intracameral space. We have also the optic nerve crush, but it's not based on high intraocular pressure, but it's actually based on the degenerative process of retinal ganglion cells. It's both retrograde and anterograde retinal ganglion cell degeneration. We do a crush here. Okay. And there are many other models in literature. We have hypertonic saline injection into the scleral veins. We have also intracameral injection of viscoelastic substance, cauterization of vortex veins, that they are vascular structures that they drain the eye as a whole, and they end up with a ocular congestion and increase in the intraocular pressure. We have also this synchrolimbo suture model, and we have also the transgenic model in mice, the DBA2J, that it's a very used model in literature. However, there are some pitfalls of the experimental models that we have nowadays. Which pitfalls would be this? So invasiveness, some of these models, they are actually really invasive, and some of them, the animals, they develop corneal opacification, and this corneal opacification precludes some functional studies of the disease. Some of them, for example, the DBA2J model, that it's a congenital, it's a transgenic model of chronic glaucoma. It has some anterior segment disruptions, and the surgical models that we have, most of them have this extensive learning curve. Others, they depend on expensive equipments, and most of them have highly variable postoperative intraocular pressure. So this is actually bad because we depend on a greater number of animals to do our experiments. And here is the limbo plexus cauterization model that we call LPC model. That it's this model that we developed in our lab based on the cautery. It's a low temperature cautery of these vascular structures here around the limbus, the cornea. So here's a video of the surgery. It's a two times speed. And then we can see here the cauterization of these vessels. It's actually non-invasive. We don't do any incision to the eye. And we perform this surgery in an area that is really exposed, so it's really easy to perform. Here I am exposing this inferotemporal area of these vessels with the aid of a curved forceps. And we do this all around the limbus. So it's a 360 approach. So the surgeon needs to take care of not burning the corneal periphery, because it can have some consequences, some intercurrences in the postoperative period. And here we conclude this surgery that it takes around 3 minutes or even less than that. And then we see these marks here, these cauterization marks all around the cornea. It's a mark that the process had success, and we can actually do a little bit more in the areas that we still see the vasculature. Okay. So what's the profile of the IOP of the intraocular pressure after this procedure? So what we see is that we have a spike in the IOP in the immediate postoperative period. So here it's immediately after the surgery. And then every day we measure the intraocular pressure, and we see actually a subacute hypertension. So in the 7th day after surgery, the IOP returns to the baseline level. Okay. And in terms of clinical recovery, so here it's a graph that I show both the onset of limbo revascularization. So we perform this model in rats, and we see actually it's a pigmented rat that a process of revascularization happens, and it's fast. And maybe this is because this is why the IOP returns to normal after some days. But this is very important because the cornea gets transparent again very fast. So actually after 5 to 6, 7 days after surgery, approximately 100% of animals, they have transparent corneas again. So this full clinical recovery, it's quick, and it's very important because it actually enables us to perform many important in vivo experiments in these animals, such as functional analysis of the retinal ganglion cells. So here's some of our results. So this is the density of BRN3A profiles, that it's a molecular marker of retinal ganglion cells after some days of surgery. And what we see is that actually we have a structural degeneration of the retinal ganglion cells after this subacute spike that we generated in these animals. So here you can see, for example, the dorsal or superior quadrant of the retina in these animals. We see a profound decrease of the density of these cells, both in the dorsal, temporal, nasal, and ventral parts of the retina. But if you can see here, it's actually a segmental degeneration. It doesn't affect the whole retina in an even manner. No, we see a greater degeneration in the dorsal and temporal parts of the retina. And this is a little bit quite similar to what we see in human patients. So glaucoma doesn't affect all the retina in the same manner. Okay, so there are some areas in the retina that the ganglion cells, they are a little bit more sensitive to the ocular hypertension insult. And here is the analysis of the optic nerve. So for us to model glaucoma, we can see only to the retina. We need to prove that the optic nerve, the axons of the cells, is also degenerated. And here is what we actually see with this model. This is the axon count here with the ocular hypertension as compared to control eyes. So we see that even after 3 days of surgery, 2 weeks, 30 days, we see a progressive degeneration both in ganglion cells and axons, even though the intraocular pressure returned to normal levels. And here is a ultrastructural analysis. We see actually degeneration in chromatin, we see a degeneration in myelin that starts even after 3 days of ocular hypertension insult. And here are some functional analyses in these animals. So we performed the optomotor reflex analysis. It's a behavioral analysis in these animals. Okay, so what is interesting here is that 3 days after the high IOP insult, after the LPC surgery, we see a profound decrease in the perception of special frequencies patterns in these animals through the optomotor reflex, but then it returns to normal. And it returns to normal in conjunction with the intraocular pressure. So you saw that after 1 week of surgery, the experimental eye returns to baseline levels of IOP, and we see actually the behavioral analysis also returning to baseline level. So maybe this first insult it's in the period that the eye is with ocular hypertension, then the IOP returns to normal. But what is interesting here is also that after 1 month, the behavioral analysis decreases again. So probably what we are seeing here, it's a secondary degeneration process. It's a progressive degenerative process that happens even though the intraocular pressure returns to normal. So as an experimental model of a disease, we could actually maybe compare to those patients that we reach the target intraocular pressure after prescribing them hypotensive eye drops, after performing many kinds of surgeries. And these patients, they still have their retinal ganglion cells degenerating and their glaucoma getting worse, okay? And we did also functional analysis with electroretinography. So this is the pattern ERG, the pattern electroretinogram, that it's a specific method for us to evaluate in vivo the function of the retinal ganglion cells. And we see after 3 days, a profound decrease in the amplitude of these waves in many different spatial frequencies. After 14 days, we see actually kind of a recovery but not in the same level of the control eyes. And after 30 days, another decrease, maybe showing us this secondary and progressive degenerative process that happens with these animals in this experimental model. So in conclusion, the limbo plexus cauterization, this is a non-invasive model. It's low cost because we actually depend only on in a low temperature cautery. It's easy learning, short learning curve. It's highly reproducible. We reach a full clinical recovery after a few days, which enables functional analysis. And we get a glaucomatous degeneration in a short time frame. So all of our experimentals, all of our experiments we performed until 30 days of surgery. So we can plan short-term experiments, and this is actually an advantage because we can have faster results, and we can depend on a few on a lower number of animals, which in terms of ethics in research, it's also very relevant. So this is all. Thank you very much, and I'll be happy to take any questions.
All right, thanks so much, Raphael. And as you mentioned, yeah, if folks have any questions, feel free to add those in the Q&A. It looks like we have one question already.
Okay. Does frequent use of corticosteroids increase the risk of glaucoma? Good morning, Greens from Chile. Thank you very much for your question. Okay, so yeah, this is a very important risk factor also, and this is very common, and it's actually a public health issue because we have many patients, many people that use chronically corticosteroids in a very varied forms. So nasal sprays, skin corticosteroids. So all them, they can increase the intraocular pressure. And what's the problem of that? Is the patient doesn't feel anything. So it's mostly asymptomatic, and the chronic use, even in young people, can make the patient have very, very aggressive forms of glaucoma. So it's very important. Every patient and everyone that use corticosteroids orally or injected, spray, nasal spray, and also through eye drops, we need to regularly see these patients. So these patients need to visit regularly his or her ophthalmologist to see if the intraocular pressure is in normal levels or if it's increasing. So it's very important. Thank you very much for your question. Okay. So King Sang asked, what do you mean about low temperature after injury on the vessels? Does the injury induce inflammation? And how does the RGC loss in your model comparing to the others? So very good questions. So we use the specific cautery, and it's low temperature because the model of the cautery that we used from the manufacturers, they say that it's low temperature. We actually didn't measure the temperature. So this is something that is important, mostly because other people may want to reproduce this model. And if you reproduce that, it's important. If you use another manufacturer, it's important for you to describe your own results. But if you use the same manufacturer that we used, and it's described in our papers, So this is the low temperature one because they also have the high temperature one. And the this model actually it induces some inflammation in eye surface and maybe also some intraocular inflammation, but it's very mild. Okay, and it's important in our JoVE paper we described our manner to approach the post-operative period. So we use some kinds of eye drops, anti-inflammatory drops, and antibiotics for us to have that full clinical recovery that we described in our papers. Okay. And how does the RGC model, the RGC loss in our model comparing to others? So we actually didn't do a direct comparison with other models. We can just compare with what is described in literature. And it can be compared in many ways. So there are some models that they have the advantage of being chronic ocular hypertension models. So in terms of modeling what happens to patients with glaucoma, this is for sure an advantage. So here we are describing a subacute model, okay? And this is a post-trabecular glaucoma model. We are not actually inducing trabecular meshwork. It's the structure of the eye globe that drain most of the aqueous humor. So we see in the primary angle open angle glaucoma, that is the most common one in patients, that we have a trabecular meshwork disease. So that's why the intraocular pressure rises. And what we see in our model, it's a post-trabecular model. So we cauterize vessels that they are distal to the trabecular meshwork pathway. Okay, so this is a model. It won't take all the characteristics of the disease. So this is why it's important if we are testing a new drug, a neuroprotective approach to glaucoma, for example, gene therapy, cellular therapy. It's very important when we are working with experiment models, for example, rodent models. It's very important for us to test in different models. For example, this subacute model, the chronic one, the transgenic ones. So if you show that a drug has neuroprotective characteristics to retinal ganglion cells in more than one model, more than one different model, this is an advantage for that drug to in terms of translational medicine for us to take this to patients. Okay.
Okay, so it looks like that's it for questions, unless anyone has any last minute ones. All right. So, yeah, I just want to thank Raphael again for an excellent presentation, and thank you all the attendees. Like I said, we did record the webinar, so we'll be sending out a recording to folks. And if you think of any other questions after the fact, you can feel free to respond to that email, and we can help you at that time. All right.
Thank you so much,
Thanks again,
Ron.
everybody.
It was a
Yep.
great pleasure. Thank you very much.
Thank you. Take care. Bye-bye.
Bye bye.